Great. Thank you, Sean. So our next presentation will be by Larry Kessler from the University of Washington. Larry.
Thank you. I'm noticing time, so I'll try to do this in the next 5 to 6 minutes. First of all, I want to thank the IOM and the panel. I apologize for missing yesterday, so if I repeat anything that you heard yesterday, I apologize for that. And I have a disclosure. I'm working for 2 companies that actually have investigational device exemptions in front of the FDA now. I'm going to note 3 problems, 1 regulatory, 1 about procedures, 1 about long-term outcomes. And then I'm going to note a collection of potential solutions. We've been charged with solutions to the gaps in evidence, and especially in comparative effectiveness research and patient-centered outcomes research studies. So yesterday you heard from Mike O'Hara of the Center for Devices. The quote from his slides is, "There's a reasonable assurance that a device is effective when it can be determined based upon valid scientific evidence that in a significant portion of the target population, the use of the device for its intended uses." And I'm going to stop there because that's the problem. Intended use is where the enormous issue of general versus specific comes to play. A lot of the products you're talking about, robotic surgery is a great example. If they come to the FDA and they claim they can cut, then that's what the FDA will clear them or approve them for. And the FDA is bound by its laws with that box. And so those general indications are very limited, and the product gets out on the market. But here is where, if the company only makes the general claim, and they're only allowed to make that claim, then it becomes time for both the professional societies and the reimbursement agencies to hold the company to that, and to not give them excess reimbursement for claims that they have not substantiated from the FDA. So there's a circle here that you can make if companies are held to what they're trying to do. And it's a pretty big loophole that I don't think Mike talked about very much. We can make this pathway more accessible and scientifically sound if we make it clear to clinicians and companies that the path forward will require adequate clinical studies in order to get the right indication for which they're actually designing the product. The regulatory bar at FDA would, in fact, be fairly adequate for those situations where a specific indication is actually the purpose of the product. So that's where people say the FDA's bar is too low. It's too low if all you're asking for is a general indication, but then that's all you get. Problem with procedures. Sean Tunis and Scott Ramsey and I published an article a few years ago about procedures, and that's actually a real problem because they fall in the Bermuda Triangle between NIH, FDA, and the Center for Medicare and Medicaid and other reimbursement agencies. Nobody legally has the authority to regulate procedures, and it's a gap that Congress should actually talk about filling. But Congress has made it abundantly clear in legislation that all of those agencies can't regulate the practice of medicine, and procedures fall in the practice of medicine. So that, at the moment, would fall to good clinical trialists like my friend James Dignan or Steve Pianadosi, or the professional societies that sometimes abrogate that responsibility by pushing procedures without adequate evidence. Long-term outcomes. Prostate cancer is a great example. We talk about randomized trials. The difficulty is with things like mortality in prostate cancer, there is no way to get fast. I mean, your triangle, Sean, would be great, except there's no way to get fast, with prostate cancer outcomes. So we wind up then having to think about both surrogate outcomes as well as adjusting the pre and post market balance. So despite Sean's concerns about coverage with evidence development, which he pioneered at the Center for Medicare, I still think that is a development we should continue to push at the national, state level, and, as was mentioned before, the situation with the Blue Cross Blue Shield Massachusetts, trials where possible and registries only where necessary. And this should actually be the default, not the exception. I think we have to turn it on its head. Right now, fancy technologies get on the market, and then maybe we do coverage with evidence development. It should be that when fancy technologies are getting to the market, coverage with evidence development should be the expectation, and then only in a few cases would you say, let's not do that. And I think that's a matter for the combination of reimbursement agencies as well as NIH and FDA to be more insistent upon that. Regulatory oversight of advanced technologies. FDA should insist on more precision in intended use, and it can do so. It does not do so because it's a regulatory burden and they're understaffed, so they don't push companies to be more specific about their intended uses. They should and they can. Also, we should leverage technology diffusion for innovative study designs. A lot of study designs now in comparative effectiveness research are using stepped wedge designs. So as innovation rolls out, especially if you can do it randomly, and we actually have probably more control with reimbursement agencies than we think. You can actually get a lot of very valuable data that is approaching an individually randomized controlled trial with step wedge, as well as cluster randomization. And we should focus more on international trials because we adopt technologies fast, other countries slowly, and we can use that degree of variability intelligently, and we're not doing so. NIH actually doesn't support as many international trials as they could in this technology area, and it would be really great if we could use that. I am rapidly running out of time, so I'm going to mention post-market systems, which are largely inadequate for a variety of reasons. There was a recent article just this week, July 17, in the New York Times about the weakness of oversight of medical devices, particularly in the post-market area, and it is likely to get actually less strong if the current bill in front of Congress passes. But there are possibilities in post-market. Sean mentioned PCORNet. There's also the new MD EpiNet, whose mission is to bridge evidentiary gaps to develop data sets and innovative methodologic approaches for conducting robust analytic studies. I think both of those have potential. And finally, one of the questions to ask is, will the move toward accountable care organizations and population health constrain rapid diffusion and then promote more coverage with evidence development? Possibly. The comments about CTAF this morning look like they have great potential. And there's a health technology assessment program in the state of Washington that's model legislation because it's a binding board that looks at value for health. It's binding on all the state payers, state-funded payers, not the privates, but that actually drives a lot of evidence in the state of Washington. And people should look at that as model legislation. It'd be great if other states adopted that. Thank you.